Okay, guys, I will ask you, everybody, just to finish, if it's possible, the coffee break so we can start on time and not to delay additionally the program. I will invite our next speaker, Dr. Alexander Sirakov, to share his experience with application of Lidocaine to treat subunit hemorrhage-related headaches.
Hi, good afternoon. My name is Alex, and I work as a senior consulting physician in University Hospital St. Ivan Ryovsky. And today I'm going to use the opportunity to shortly brief you about an extremely interesting, in my mind, also exciting concept that we have successfully employed in our department, or in other words, the application of lidocaine in the middle meningeal artery for the treatment of aSAH-induced headache. So I guess I have to click. I don't have anything to disclose in relation to this presentation, but on the other hand, I would love to use the opportunity to honorably mention and express my frank gratitude towards those two friends of mine. Dr. Paul Bogau for sharing the theoretical concept and the idea with us a few months ago, and Professor Dr. Adnan Qureshi, who pioneered his work with the application of lidocaine in patients with refractory migraine back in 2014 and 2016. So a few words about the problem, a little background. We all know that the headache is the leading symptoms in patients with aSAH, and almost all of the patients with the bleeding will report a severe or insanely intense headache at some point during the admission. Currently, we don't have any established guidelines or managemental protocols for the therapeutic approach. So the regular use of opioids has no effect on the length of the hospitalization. And unfortunately, the regular use also puts them on some sort of addiction and requires the opioids to be continued during and after the discharge in the hospital. What troubles me the most is that we don't have any clue what is the common cause of the headache in general, and especially the aSAH-related headache. There are a few proposed theories, one of which are more profound, suggesting that there is a pyovasodilatation after cortical desensibilization, but there is no that much of an evidence to back up this theory, and that's the reason why many of the neurological specialists and pain doctors are moving away from this concept. Now, what is really interesting is the long-term data that was published recently by Hook-Hagel and colleagues, and they did a wonderful prospective single-center cross-sectional analysis, and they found out that nearly half of the patients and half of the survivors actually complain of a burdensome headache that can last up until 3 years after the initial event has occurred, which is something fascinating. Marking the fact that the headache is not only an acute problem, but more likely to be a chronic problem as well. So if you look if you look deep into the data, you can see that those patients actually have worse quality of life. They complain of depression, sexual dysfunction, inability to go back to work and restore their work-life balance. They suffer from PTSD, etc. So what bothers the most is that problem that the headache might be the root cause for the inability of the patients to go back to work. Unfortunately, opioids remain the first-line therapy for the management of aSAH-induced headache, and we know for a fact that their effects are being overthrown by the negative side effects. We all know that many of them can actually mimic or undercover symptoms of vasospasm and significantly reduce our ability to properly evaluate the neurological status of our patients during rounds. Therefore, there has been some sort of a tendency, or maybe opioid sparing, a shifting paradigm, but unfortunately the supporting evidence for the use of other alternative approaches is limited and basically scarce. There are a few existing and ongoing randomized control trials that are actually trying to evaluate the new managemental drug protocols like gabapentinoids and other medications, but I guess we have to wait and see the initial results. It is worth mentioning that there is an interesting trial going on as we speak in the USA, connecting and recruiting across 12 centers, called the BEC aSAH study, that aims for pterygopoietin ganglion blockage to alleviate that aSAH headache symptom. Now to the point, why do we select it and went for lidocaine application? As I mentioned before, the pioneered work was done by Professor Adnan Qureshi back in 2014, where he actually treated a dozen of patients with refractory migraine. And when I say refractory migraine, those patients were totally resistant to the suggested managemental drug protocols that we have available nowadays. So what he saw was actually fascinating by me, is that he recorded almost instant cessation of the headache after application of the lidocaine in all patients. That's extremely exciting. Especially those patients report of reduced score of pain even after weeks to months after the application of the lidocaine, which doesn't make sense with the common knowledge that we have from pharmacology, given the fact that the lidocaine has only a few hours of half-life. That doesn't make any sense. So I think Dr. Elonsky had a presentation on chronic subdural hematomas, and our colleague from Netherlands as well. They both emphasized on the fact that we learn from the literature and we know from daily practice that patients with chronic subdural hematoma do have some burdensome headache as well. And what we've seen from the MMA occlusion is that those patients are actually stop complaining of chronic burdensome hematomas, headaches as well. So there has to be a connection between the MMA as an artery, the dura as an involvement, and the source of the nociception of the brain and that pathological headache mechanism. So that's the reason and the general concept why we decided to try the application of lidocaine in patients with burdensome aSAH headaches. And without further ado, let's go straight into the results. So, and I have to apologize to the audience. So far to that very point, we have done more than 80 patients, but I failed to analyze them and prepare them in a proper presentation. So we're going to emphasize on only, let's say, approximately 50 of the cases that we have done for the last quarter of 2025. The data does not differ, our demographics do not differ from the data that has been already published with the data for aSAH and ruptured aneurysmal cases. So far, but to be fair, there is a huge selectional bias in our group because we had to cherry pick patients that are in good neurological condition in order to double check and confirm in order to allow them to verbalize their pain scores and to make sure that everything is correct. That's why we rendered majority of the patients to be in Hunt-Hess1 and Hunt-Hess2 of a score. Now, only a couple of patients were presented with perimesencephalic non-aneurysmal aSAH, and the remaining were patients predominantly with non-traumatic aneurysmal aSAH. All the supraarachnoid hemorrhages were diffuse, 51% grading Fisher scale of 4. All the other patients underwent endovascular treatment and the vascular repair of their aneurysm. So at the conclusion of the coiling and the aneurysmal treatment, we had to position a microcatheter proximally to the petrous branch of the middle meningeal artery and then infuse lidocaine with, I would say, rapid injections of lidocaine. At the dosage-wise, I have to mention that we were extremely scared of applying lidocaine directly to the petrous branch and the middle meningeal artery. We were unaware of the side effects of the lidocaine applied into the skull cavity. And we started slowly with 5 milligrams, but then we gradually increased the dosage up to 50 milligrams, and we haven't seen any lidocaine-related side effects like cardiovascular arrhythmias or any possible drug-related counteracts. In the majority of the cases, we've aimed to embolize bilaterally, but in cases when boss was in a hurry or maybe it was a Friday night or case over the weekend, we went for the unilateral predominant of the aSAH side. Pain score-wise, before the treatment, all of them were in agonizing state. All of them reported agonizing and extremely significant headaches. So similarly to Adnan's work that I've mentioned, and despite the fact that he published on migraines, we saw almost complete cessation of the headache instantly after the application of the lidocaine. That overlasted, for sure, the half-life effect of the lidocaine. We have seen resolutions of the headache to the points where the headache was scored 1 to maximum of intensity of 2 for more than 72 hours after the application, which doesn't make any sense to me pharmacologically speaking. We managed to convince our extremely stubborn ICU doctors and anesthesiologists not to use and to spare the opioids as much as possible, and we yield results in which 82% of the admissions were opioids-free at the point of the hospital stay. And we managed to control any residual headache only with non-steroidal drugs, which is really encouraging results from my point of view. Now, the most interesting part is the prolonged effect. We don't know what is actually causing this. Is there any sort of I had a similar talk in Brain 2025 last December in London, and one of the guys was actually had a fascinating PhD in pharmacology. He said that the possible link between the prolonged effect of the lidocaine might be some sort of a preservative that has been deployed in the syringe or the ampule that we're using. But I failed to confirm the presence of any preservatives in the lidocaine ampule that we're using. Majority of the patients kept the worst course of their headache for 5 to 7 days after the applications. And to be fair, I'm pleased to share that we managed to do phone interviews, or if the patients came for a diagnostic follow-up, we managed to interview half of the survival group. And to be fair, the data, the long-term data, 3 months, 6 months, and 1 month controls, they look fascinating. They do not fit the criteria that Hook-Hagel reported, up to 41% of the percentage of the survivors having a long, profound, burdensome headache. So I think we're doing a great job. And just to be precise, I mean, I will play a few videos just to show you how big of the effect is. This is a patient that we have meted for rupture MCA aneurysm. You can see that there is a meningoradicular irritation. Obviously, we examined every patient. Neck stiffness, extremely painful, Kerningen-Brzezinski neurological test. After the application of the lidocaine, we saw almost complete resolution of the headache. Look at the face of the patient. It's no longer agonizing. The patient does not it looks happier than before the treatment. Of course, that was due to the aneurysm embolization and the satisfactory occlusion, but nevertheless, we saw something really interesting. Alongside the alleviation of the headache, there was a resolution of the meningeal syndromes. So that's another confirmation that the dura might be involved in the headache in the first place. So what are the possible mechanisms of action? To be fair, I don't know. I don't have any clue. I sincerely don't. And I invite the audience to help me if you have any idea how the lidocaine is actually doing this. So we did some extensive literature with Paul, and we found out this article that was published a few months ago in 2025. An amazing group from Amsterdam. They did that article might hold the key in the possible explanation behind the headaches in general and aSAH-related headaches, and why the lidocaine actually helps. So the group examined the vascular responses to molecular migraine triggers in patients with history of migraine and healthy controls on the MRA. Now, all the patients in all the patients, vasodilatation of the middle meningeal artery was statistically and directly associated with the presence of headache in general. And now, on the other hand, the authors managed to identify a specific molecular trigger, calcitonin-released gene peptide, which was actually triggering migraine or headaches in all of the patients in the migraine group, and migraines in, let's say, 75% of the patients without any history of migraine. So could it be that molecular trigger, the calcitonin gene released peptide, could be the link between the headaches and the vasodilatation of the MMA? I don't know, but for sure this is one of the most powerful vasodilatators known to human body. What we know from physiology and pathophysiology is that this molecule it has been stockpiled in the trigeminal ganglion, and as soon there is a aSAH, the body tries to fight any potential vasoconstriction syndromes that occur following the aSAH. So it releases tremendous or significant amounts of that very molecule in the MMA circulature or along the pathway of the MMA next to the C fibers that travel along the dura and the middle meningeal artery, causing that vasodilatation. So is the vasodilatation of the MMA also a key to the headache in general? As I said, I don't know, but we know that maybe overstretching the artery leads to an increased potassium ion efflux into the perivascular spaces, causing another further sensibilization of the nociceptors, and then across all the neurons that travel into, next to the MMA. Now we know for a fact that, and from basic pharmacology, that the lidocaine is known to inhibit the potassium ATP-dependent channels, but also interfere and basically interrupt the CGRP signaling pathways, and thus interrupt the vicious circle that the human body is being exposed to after the aSAH trigger or the ictus of the bleeding. Now, interestingly, we have applied lidocaine in MMA, and we've seen drastic vasoconstriction, which is contrary to the fact that we know that lidocaine actually is causing vasodilatation. And here, have a look. This is the middle meningeal artery before the infusion, the first image, and then following the infusion of only, let's say, 10 milligrams of lidocaine directly into the MMA, just below the petrous branch. This is a perfect example. Where do we actually prefer to position that tip of the microcatheter? Just proximal to the petrous branch. So far, we haven't seen any related complications. We haven't seen any, let's say, facial nerve palsies, trigeminal palsies, ocular, visional symptoms, cardiovascular interferences, nothing. Methylhemoglobinemia, nothing. So I think it's a really, really promising way. I don't know the mechanism of action, as I said. I don't know if it's the constriction. I don't know if we're like manually resetting the trigeminal ganglia. I don't know if the GCRP is actually related to that process somehow. We simply don't. To be fair, we managed to establish a grant to the Medical University of Sofia to double check the serum levels of that molecule and to see if we're actually doing something to the nociception pathways. But we have to wait and see. The only purpose of this presentation is to clearly encourage you guys to spend 5 more minutes after you've done with the coiling and you've done with your procedure. Go to the Ipsy water, or if you care, the bilateral side of MMA. Apply a few drops of lidocaine and see it yourself. The happy faces of your patients are going to convince you that this procedure is worth to try. Thank you.
Thank you. Thank you very much. I already see raised hands.
So thank you very much for this interesting presentation. So it's a new field. So what's your next step? You say it's like, would be default treatment, or would you randomize patients in a trial for this?
Yeah, sure. We try to, but I mean, we couldn't find any enthusiasts to join for a bigger trial, multi-center trial and approach. The next step, to be fair, Dr. Adrian Qureshi has a really cool concept that I'm not sure I'm able to disclose because of an NDA, but yeah, there might be a device that provides a solid long-term solution to that headache, especially in those patients. And the device that might be the solution for chronic refractory migraines as well. So that would be my future perspective. But nevertheless, try the infusion.
Thank you, Alexander. Very nice and extensive. Also, your review on the potential mechanism.
Potential,
Yeah.
really potential.
So my question is about the applicability.
Yeah.
Because, basically we're talking about Hunt and Hess 1 and 2 patients.
Yes.
Right? If they are 3 and above, they're comatose. Why would you care if
I will tell you why. So I might be totally biased. As I said, there is a huge selectional criteria bias, and we did that on purpose just to make sure that the patients can vocalize their pain scores, right? Because the pain scores are already being something subjective. Now, to put things into comatose patients and high-grade Hunt-Hess scores, our department is one of the main neurosurgical centers in the whole country, and we do services for, let's say, the whole country. All across the year, we get approximately 180 cases of ruptured aneurysms. So we are dealing with patients in comatose states in Hunt-Hess 3 and 4, etc. What are the benefits in those patients? As I said, I might be biased, but for the last 2 years, starting from, let's say, last 1.5 years, September 2025, we started to infuse routinely. And we've noted only 2 patients that required pharmacological management for their vasoconstriction syndrome. That does not fit the previous data. That does not fit our previous experience. We used to have more spasms after aSAH. And interestingly enough, I haven't seen that much of a delayed cerebral ischemia that we often see, like those hypodense zones scattered across the white matter that we used to see with aSAH patients. So are we somehow affecting the microvasculature of on the surface of the brain? Are we reducing chances of having our patient exposed to post-aSAH vasospasm or DCIs? I sincerely don't know, but I am keen to share our data, all the CTs that we've done, all the follow-up CTs that we've committed to somebody to have a look at them and decide for ourselves.
Yes, and then so if you want to implement this in the future, yeah, then you would do it upfront, during coiling, after coiling?
After coiling. You just draw the guiding, you navigate to an MMA. Sometimes it's possible, sometimes it's not. To be fair, we've all did it like numerous times, and we at the start, we cared about those branches that you see, that you presented. Now we don't, because sometimes we were in a hurry, we missed them. We didn't see the opacification of the lateral, the medial angle of the orbit or the lateral angle. We infused lidocaine, we haven't seen any retinal damage. We might see some at some point when we miss the ophthalmic connection, the direct one, but so far we haven't seen any contraindications and pathological reactions to the lidocaine application. So yes, it's our routine protocol now. I know 5 minutes takes a lot, but I think that when you go into the ICU and look at the lady. Take a look at her. That's before the embo. Do you see the agonizing headache?
I am having the mental image, but no, thanks.
Sorry.
I think.
Can you put it on display? Yeah, look at this. This is the lady before the infusion. She's about to go down for CTA and embolization. Lady goes back, let's say, to be fair, 6 hours after the extubation. Look at the resolution of the meningeal syndromes. Now she can use a pillow, and now she can smile. Definitely. Her face tells you that she's no longer agonizing.
But thank you for showing this and doing the cases.
Yeah.
There are cases, the rupture cases,
Yes.
immediately after coiling, when they woke up, they didn't feel pain, and you may think that because of the anesthetic drugs, but after a while, still haven't got pain. And that artery aneurysm itself, we know that the pain coming from arteries and also dura.
Yeah.
But eventually, there are cases also, because of the lumbar puncture or external drainage, to get rid of the pressure in the subarachnoid space, eliminate the headache.
Sure.
That is for sure. And now we are thinking to eliminate the intracranial hypertension, that is the subarachnoid space pressure gradient increasing without enlarging the ventricles. We called pseudotumor. That is now coming, proofs coming because of the venous system stenosis is one of them. And now in the subarachnoid space hemorrhage, we are certainly increasing the subarachnoid space pressure. And now you are dealing with get rid of the trigeminal nerve territory by using short-acting drugs. Again, the same things happening in the dural stenting that I mentioned before to you, when you have a radial bore, radial force, and force the dural channel to be circular, you can create headache. And so this is a kind of a facet circle, maybe that drug, eliminate that facet circle to get rid of the pressure, and then or get rid of the trigeminal impulse to do inflammatory process. We didn't know that. I believe eventually we will learn. It needs to take time to work on it. But eventually, whatever you do maybe is a part of the game we need to do together. For example, for me, more routine, if I had a headache, my patient had a headache, I will, if there is no herniation problem, I will certainly do a lumbar puncture. Or time to time we are putting the cannula on it for certain days to get rid of the pressure. And external drainage, the same thing. And this is a difficult task, but thank you for showing so.
Well, definitely, we believe that we're not like providing any panacea or sort of an established treatment, but the point is to push the envelope through the society to request more feedback on the treatment, and like we need to find a solution. We're definitely going to deal with this pathology, but yeah, I think that's the correct way. Let's see how it goes with the microbiological and molecular tests.
So that's our field is so new, if I may just add. So when we can add something new for our patients, see them on the intensive care, and if it doesn't work and it's not risky, it's worth to try.
Why not? Additional benefit always.
Of course, with less risk of complication. Okay, thanks. So I have to introduce myself for the next presentation. I will share our experience with intravenous application of Avastin in glioblastomas. Hello to all. Thank you for coming. Thank you for the organizing committee. I'm honored to invite me one more years in a row to share. So I decided not to share the same stuff every year, like aneurysms, AVM, stroke. This year, like you saw in the program, we decided to be a little bit more different. That's why we asked Professor Kutzer, Professor Herstern to share different pathologies inside the neurofield we are dealing with. Today I'm going to share again a new idea coming to our department, trying to control, if I may so, or contain this pathological disease, which is a glioblastoma by itself. So we try to combine cannabinoids with intra-arterial application of bevacizumab. Of course, systematically, the temozolomide was synergic treatment stayed at the patient. All of you know that glioblastoma is the most aggressive primary brain tumor in the adults and remain the major limitation to the patient's survival. It's marked cellular and molecular heterogeneity, together with pronounced angiogenesis and invasive growth leads to a rapid progression and very, very often to resistance to therapy. And despite the extensive research, prognosis still remains very poor. Maybe the median survival rate is approximately 12 to 15 months. So what changed through the years dealing with this pathology? The treatment landscape of glioblastomas has evolved substantially, of course, over time, from the early radical surgical approaches and radiotherapy combined with chemotherapy. And the current standard of treatment is like a STRUP protocol, which means maximal safe resection as possible, followed by radiotherapy and concomitant and adjunctive therapy by temozolomide. However, recurrence remains very often and remains common. Newer strategies therefore includes tumor treating fields like target therapies such as EGFR and VEGF inhibitors, immunotherapy approaching including CAR T cells and vaccines even. You remember the time they're like a hype or fashion, using the vaccines combined with the treatment of glioblastoma. So most of them are drug delivery aimed to overcome this so-called, to overcome the blood-brain barrier and to be active inside it. The blood-brain barrier is the problem we have to dealing with. So we can be active and to put the drugs mainly inside the tumor so it contains its growth and progression. And that's of course very true about when we're speaking about the glioblastomas. The obstacles should be considered as one of our enemies that needs to be defeated, so go inside the tumor. You might argue that when we see the peritumoral contrast enhancement on the CT or MRI, this is already indication of disrupted blood-brain barrier. And partially, it's true. However, glioblastomas extends beyond the enhancing margins, you see. So the tumor cells infiltrate the hyperintensity and flare regions that do not enhance. So meaning, there are still tumor spread across the main stroke and beyond the visible area of the blood-brain barrier we are break down. So we have to figure out how to pass these barriers. So how to be more active inside the tumor for a longer time. How to attack the tumor itself that's hidden and that we cannot see around the main target area. And that might make sense since the GBM should be considered as a whole brain disease. And the reason is, like this, even look at the dentist's first description when he says colleagues with hemispherectomy and then the tumor cross the border from the other hemisphere. There are different ways to achieve the so-called blood-brain barrier opening or disruption, so we can improve getting more of the drugs inside the tumor. The osmotic blood-brain barrier opening with mannitol is proven an effective option because it stays open for quite some time after the mannitol is injected. Some authors say it could reach up to 40 minutes. And this creates the opportunity for the endovascular approach, for our field to go direct intra-arterial drug delivery in the tumor, close to what we are dealing with liver tumors, for example. Bevacizumab is a well-known established, but when given intravenously, its effect is limited to the poor blood-brain barrier penetration. So, the key question is how we can improve it, how we can improve the effectiveness of existing therapies nowadays. Given the EI after osmotic blood-brain barrier opening is the best way to give this drug and to stay as much as possible. Of course, the washout effect is there, but we are targeting directly the tumor itself, and we potentially maximize its effect. Interestingly, the effect of bevacizumab appears to be dose-dependent. At the higher concentration, it provides both a direct anti-tumor effect and very strong anti-angiogenic effect also. This is why the intra-arterial delivery after a blood-brain barrier opening is very attractive options to chase out. It allows much higher local drug exposure inside and also the tumor region around. Unfortunately, the tumor has multiple ways to avoid this, of course, drug effect, aka escape mechanisms possible due to molecular heterogeneity, rapid angiogenicity, and rapid regrowth and growing. Targeting tumor escape mechanism is therefore essential. Much like the multi-drug resistant tuberculosis, a single agent is rarely sufficient, so we do combinations. A rational combination of the therapies acting synergetically on a different pathways may be the key for achieving this more durable response to the drug we are acting in dealing with the tumor. And yes, the cannabinoids may be the answer we are looking for. We look to the literature, and a lot of you maybe also have it, and we found already it's proven. Their anti-tumor properties have been described already, and especially their application in GBMs. So does it work with combination with bevacizumab? We managed to identify an original work that demonstrates that there is synergetic action between those two methods application synergetically, going together. So the question is, can we actually introduce the combination safely? That was the idea we are trying to deal with and to discuss. What do we need to do actually? So we try to add CBD and to understand, does the CBD works alone, or we need also the both THS to be included? And the THS has more synergistic effect coming together with the CBD. So it's maximize the effect to stay the target area for longer time. And if you look at this data, you can see the strong anti-cancer properties of the combination of the CBD and THC by itself and chemotherapy systemically. Cannabinoids alone have been tested for treatment of glioblastoma. It doesn't show great results, but they improve something. So the drug called Sativex contains CBD and THC in 1-to-1 ratio. And if you look at the safety profile, side effects appears to be very, very minimal. So thanks to idea of Dr. Paul Bogao and of course allowance of our neurosurgeons. I should mention Professor Minkin from our department, which was agreed to test on a patient which has inoperatively residuals of the GBMs on which we can try this, our idea. So we thought we can actually combine the drugs and explore its effect of residual or recurrent glioblastomas. This is the proposed protocol we have done together. So we start at least 5 days before the intra-arterial application, if it's possible, because in Bulgaria it's not very easy to get, but if the patient starts with Sativex, and then in 5 days we do the first application of intravenously bevacizumab after blood-brain barrier opening with mannitol. So we do this 25% mannitol, we wait 3 minutes and starting to, not selectively, but in the internal carotid artery from the area of interest, we do not super selectively what I meant, we do intravenously the bevacizumab. So the problem is the cost. Most of these patients have to pay or to find the bevacizumab, which is very, very expensive here in Bulgaria, and to get the access for the Sativex. So I will just show you several cases we have gathered until now. We observe both very nice effects, very good contents, and no effects at all with regrowth of the tumor. So this was the first patient. You see the initial MRI and 6 months point in which we have decreased enhancement around the massive, the first operation field and mass effect around the residual tumor with no complication and no major side effects. This is the second one, again, prior to our treatment, and 9 months later, we again didn't see any progression of the tumor with no mass effects around. And again, no complications, maybe prior or caused by our therapy, which we gave to the patient. This is a patient which, for the 6 months, we saw even worsening of the symptoms. So maybe our selectively infects was not so good. I think was the patient without the cannabinoids. I think in this case, he didn't mention to find it, but we see progression of the tumor itself here. This was another patient with the progression. This is a 4 months difference between the two MRIs. Of course, no side effects or complication about the treatment, but no contains or regression of the tumor itself. One more like this, we observe progression of the tumor itself, the lesion, and the peri-edema around it. One more patient, 3 months difference in the both MRI. We are not sure here, should we call it progression or no. We don't see any new enhancements of the tumor, but a little bit maybe more edema around it. It's a CT on MRI, so maybe we can be skeptical here, but maybe a progression. Another example, 6 months differentiation between the two examinations. We see very nice regression of the tumor without any adjunctive therapy except our cannabinoids with intra-arterial bevacizumab. So until now, are the results good in your opinion? Is there room for improvement? I think yes. Can we change somehow the regime? Can we optimize the protocol? Are we missing something? Can we add something in this devastating disease? We are very open for idea. I just want to share this work with you and maybe coming for a new way to contain or maybe prolong this kind of disease. Thank you for your attention. I just want to mention the team behind the idea and the animal study and works they have done. Thank you. Any questions from the audience?
Thank you so much, because I think that this will be the next frontier of the endovascular treatment, maybe in the next 3 or 5 years. And if I may, I would suggest you to use high-intensity focused ultrasound to open blood-brain barrier. We started using this in 2019 in animal models, and we have seen that it's much more effective, more durable, and you can select more effectively the part of the brain that you want to treat. In my opinion, for sure, the super selective intra-arterial drug delivery is very effective. We are working on nano microparticles that will be like carriers for mRNA and drugs. But thank you so much, because I think that will be the next frontier, and it's very aggressive disease. Unfortunately, it's not so easy like it seems, because there's a lot of implications about the subtypes of glioblastoma, so we have to do more study about that, but for sure this is the first step in the right direction.
Thank you. Like I mentioned, we were dealing with only unoperative residual glioblastomas, which our neurosurgeons decided to let us try. So this bias selection by histology and subtypes, we cannot do it nowadays. Also, we try to think for super selective at the beginning, but we saw the data in the literature, they show similar results when you actively open the blood-brain barrier. So should we go very selectively in something we are not sure what we are dealing for? Are we getting a high percentage of complication by chasing such? We don't know, so we start more conservative at the beginning and maybe to see if, does it work, does it helps with less rate of complication, of course, at the beginning. But thank you for the suggestion, for sure. So thank you. Let me just check who is the next presentation.